Hey there, I'm Matt Schaefer, and today we're going to talk about skin cancers. As an overview, we're going to talk about non-melanoma skin cancers, and then we're going to go into depth about melanoma, including surgical management, sentinel lymph nodes, and whether or not to do a lymphadenectomy. Starting with a general overview of the skin is the largest organ in the body, and it functions as a barrier, maintains homeostasis, and contains sensory, secretory, and excretory glands. The skin itself has three layers: the epidermis, the dermis, and the hypodermis. And the epidermis contains the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Dermis contains glands and hair follicles, and the hypodermis is where you find your subcutaneous tissue, including vasculature and adipose tissue. Non-melanoma skin cancer is the most common cancer and is probably underreported in cancer registries, and approximately 1 in 3 people will develop a non-melanoma skin cancer in their lifetime. Starting with basal cell skin cancer, this is the most common type of skin cancer, representing about 80% of all cases of non-melanoma skin cancers. This arises from the hair follicles that are only on hair-bearing skin, and 90% of cases have a mutated hedgehog pathway. Some common risk factors are intense or intermittent sun exposure, fair complexion, immunosuppression, chemical exposure such as arsenic or tobacco or tar, exposure to ionizing radiation, and personal or family history of skin cancer. There are some genetic syndromes that predispose people to skin cancers, including xeroderma pigmentosum, albinism, Muir-Torre syndrome, Fanconi anemia, etc., etc. There are a few different subtypes of basal cell carcinoma, each with different presentations. The nodular subtype usually is small, translucent, or pearly with razor rolled edges, typically occurring on the head and neck. About 15% of the time it occurs on the trunk or extremities. The superficial subtype is a slow-growing, scaly pink plaque, more common on the trunk or extremities. Sclerosing and morphiiform subtype is the rarest form of basal cell with poorly defined sclerotic plaque. And there's a basosquamous subtype, which has features of both basal cell carcinoma and squamous cell carcinoma. For diagnosis and staging, you want to make sure you do a thorough history and physical exam. Definitely make sure to palpate any regional lymph nodes, and depending on the patient's history of cancer, potentially do a full body skin exam. And then, of course, you want to get a biopsy. Any pigmented lesion should get a punch or a deep shave biopsy, because you really want a full thickness evaluation. Some high-risk features of basal cell include greater than 2 centimeters on the trunk or extremities, poorly defined margins, recurrent disease, immunosuppression, perineural involvement, or some of those rarer subtypes such as sclerosing or morphiiform, infiltrative, etc. In rare cases of locally advanced or metastatic disease, you can use hedgehog inhibitors such as vismodegib for neoadjuvant therapy. Typically, basal cells are going to be treated with a wide local excision. If there are low-risk features, you can use a 4mm margin. If there are high-risk features, as previously mentioned, you can resect with an 8mm margin. And for cosmetically sensitive areas, you can do Mohs micrographic surgery and local advancement flaps. Rarely, these patients will need adjuvant therapy, and you can consider radiation if you're not able to get clear margins during surgery, or the patient is unwilling to undergo surgery, or even if you think you got margins, they end up having positive margins post-operatively. For follow-up, patients will need a history and physical, including a skin exam every 6 to 12 months for 5 years, and then annually after that. Moving on to squamous cell carcinoma, this represents about 20% of non-melanoma skin cancers, and this originates from the keratinocytes of the epidermis, with a few variants as well. Generally speaking, the risk factors are the exact same as for basal cell carcinoma. Keep in mind that actinic keratosis is a precursor lesion, and chronic wounds, such as from burns, can predispose to a marginal ulcer and development of squamous cell. These lesions are typically going to be red, poorly defined plaques or nodules with an ulcerated surface, present with induration or an adherent crust with ill-defined margins. For diagnosis and staging, it's going to be similar to basal cell, do a thorough history and physical, and make sure to palpate any lymph nodes, and make sure to get a deep tissue biopsy. SCC is also going to be treated with a wide local excision. Again, for low-risk tumors, you can excise with a 4mm margin. For high-risk tumors, you'll want a 6 to 10mm margin. And again, in cosmetically sensitive areas, you can use Mohs micrographic surgery. And if they have high-risk features, just like with basal cell, you can consider a sentinel lymph node biopsy, or in very rare cases, potentially a lymphadenectomy. For patients with locally advanced disease and clinically positive nodes, you can consider neoadjuvant therapy with immunotherapy. And like with basal cell carcinoma, if you're unable to get margins, or you have extensive perineural or lymphovascular invasion, you can consider adjuvant radiation. Follow-up's a little bit different from basal cell. In this case, you want a history and physical every 3 to 6 months for the first 2 years, and then every 6 to 12 months for the next 3 years. And then once you're at the 5-year mark, then they can move on to annually. Now, Merkel cell carcinoma is a little bit different. This is a rare neuroendocrine tumor that's aggressive and associated with a high risk of metastasis and recurrence. It's thought to originate from Merkel cells, which are neuroendocrine cells that lie just below the epidermis and contribute to tactile and sensory neuronal signaling. And the average age of onset for Merkel cell is the 7th decade of life. The risk factors are fairly similar to BCC and SCC in that sun exposure, fair skin, immunosuppression, UV damage, and then also Merkel cell polyomavirus. These typically present as a reddish-purple nodule with rapid growth and may be pruritic and may bleed. For these, you'll want an excisional biopsy with H&E staining, which will show small round blue cells. And you'll want to get CT of the chest, abdomen, and pelvis, or potentially a whole body PET scan, and plus or minus an MRI of the brain based on symptoms or suspicion of metastases. Surgical management of Merkel cell carcinoma is with a wide local excision with 2-centimeter margins down to the level of fascia, regardless of the size of the lesion. And you should also get a sentinel lymph node biopsy because occult nodal disease is the single most important prognostic factor in Merkel cell carcinoma. Patients with locally advanced primary tumors or clinically palpable nodes should be referred for neoadjuvant immunotherapy. And adjuvant therapy is with radiation for tumor size greater than 1 centimeter, salvage for recurrent disease or inability to re-excise positive margins at the primary site, or radiation to the nodal basin in the absence of a sentinel lymph node biopsy, a positive SLNB without lymphadenectomy, or bulky nodal disease such as 4 or more axillary nodes or 10 or more positive inguinal nodes, or extracapsular spread. Follow-up is going to be similar to squamous cell carcinoma, so history and physical every 3 to 6 months, but for 3 years instead of 2 years, and then every 6 to 12 months after that. Now, dermatofibrosarcoma protuberans originates from fibroblasts in the dermis and presents as a skin-colored nodule or plaque due to the overlying epidermis, and fibrosarcomatous transformation occurs in 5 to 15% of these tumors. DFSP might be described as fascicular whorls of spindle cells, whereas FS-DFSP will be described as architectural transformation into a herringbone pattern. And over 90% of these tumors exhibit a translocation between chromosomes 17 and 22, which results in overexpression of platelet-derived growth factor receptor beta, and that contributes to these tumors' responsiveness to PDGFR inhibitors such as imatinib. DFSP most commonly occurs in Black patients with onset between 20 and 50 years of age. These are cutaneous soft tissue sarcomas arising from fibroblasts and often present as a nodule, sometimes with discoloration, and sometimes as a plaque-like lesion. DFSP can be diagnosed with a punch core or incisional biopsy. For FS-DFSP, recommend imaging the draining nodal basin and a CT of the chest to evaluate for metastases. Otherwise, you can get an MRI of the region for operative planning. These will be treated with surgical excision, with a wide local excision, or some might call it a radical resection, with greater than or equal to 2 centimeter margins, or Mohs surgery for cosmetically sensitive areas. And important to note that these are actually sarcomas, so they don't spread through lymphatics and do not require a sentinel lymph node biopsy. Patients with locally advanced primary tumors or metastatic disease should be referred for PDGFR testing and consideration of imatinib. And for adjuvant therapy, you can consider radiation for patients with positive margins or high-risk features. While metastatic spread is rare, local recurrence is pretty common, actually up to 25% of cases. So for standard DFSP, you want to get a history and physical every 6 to 12 months without routine imaging. But for FS DFSP, you want to get a history and physical with a chest x-ray every 3 to 6 months for 2 to 3 years, then annually for 10 years total. Now, cutaneous adnexal tumors are a little bit different. These are rare tumors that arise from the adnexa of the skin, aka the hair follicles, sebaceous glands, apocrine glands, or eccrine glands. And the risk factors are also a little bit different. These are more common with increased age, with median onset of 70 years of age, and associated with certain genetic syndromes, including Brooks-Spigler, Birt-Hogg-Dubé syndrome, Muir-Torre, Cowden, familial cylindromatosis, and multiple familial trichoepithelioma. These typically present as pink or skin-colored nodules, usually pretty small, less than 1 or 2 centimeters in size. And diagnosis is ideally with a punch or incisional biopsy. You can get a preoperative MRI or a CT for large tumors, those greater than 2 centimeters, for surgical planning. And surgery for malignant tumors is going to be a wide local excision with 1 to 2 centimeter margins. And follow-ups with a history and physical every 3 to 6 months for 3 years, then every 6 to 12 months thereafter. Some other non-melanoma skin cancers include extramammary Paget disease, which is either a primary cutaneous adenocarcinoma or a tumor with secondary cutaneous involvement from an underlying disease. These lesions might be susceptible to trastuzumab depending on their HER2 expression. And then we have cutaneous leiomyosarcoma, which arises from the dermis in the 6th or 7th decade of life and typically is found on the extremities. It usually presents as a growing flesh-colored nodule, often on hair-bearing areas, and is associated with hereditary leiomyomatosis and renal cell carcinoma. This is worked up and treated like other sarcomas with better survival rates relative to other soft tissue sarcomas. And follow-up includes every 6 to 12 months with local and chest imaging. And now we're going to move on to melanoma. The etiology and risk factors are pretty similar to our basal and squamous cell cancers. These are less common than basal or squamous cell, but more common in fair-skinned people, more sun exposure, later in life, etc. And as we all know, we want to pay attention to the ABCDE rule for patients presenting with pigmented lesions. A is for asymmetry, B is border irregularity, C is color, D is diameter. Specifically, we're looking for diameter greater than 6 millimeters. And E is for evolution. How is it changing over time, especially in about a 6-month time period? One other thing to look for is the ugly duckling sign, aka a mole that looks different from the other moles or pigmented lesions around it. The most important prognostic factor for melanoma is the depth of invasion. So for these, you want to make sure that you're getting a full thickness biopsy or a punch biopsy, getting down to the adipose tissue to adequately assess how deep those melanocytes are invading. And as with other skin cancers, you want to make sure you palpate the regional nodal basins, evaluating for any clinical lymphadenopathy. Our T stage is determined by the Breslow depth or thickness of invasion and whether the lesion is ulcerated, and that will help determine which clinical pathway that we go down, as we'll see in the next slide. And then for staging, it depends on, just like most other cancers, your TNM staging, which we determine on pathology after surgery. The key takeaway from this slide is really for consideration of your sentinel lymph node biopsy. And what we're mainly looking at is whether the tumor depth is less than 0.8 millimeters with high-risk features such as ulceration. With high-risk features would classify you or qualify you for sentinel lymph node biopsy. Otherwise, if the tumor depth is greater than 0.8 millimeters, you should consider and you should perform a sentinel lymph node biopsy. So you have a patient, they've been diagnosed with melanoma, you got your punch biopsy, and you have the appropriate depth that helps you determine whether they're going to need a sentinel lymph node biopsy. It also helps you determine how wide of margins you're going to get when you perform your actual treatment, which is a wide local excision. For melanoma in situ, you can consider 0.5 to 1 centimeter margins. For melanomas less than 1 millimeter in Breslow depth, you can use 1 centimeter margins. If the lesion is 1 to 2 millimeters in Breslow depth, you can use 1 to 2 centimeter margins. And then anything greater than 2 millimeters in depth should have 2 centimeter margins. After surgery, once you get your pathologic evaluation for your TNM staging, you can consider referring these patients for immunotherapy with nivolumab or ipilimumab. And for follow-up, stage 1A to 2A patients with no evidence of recurrent disease can get skin checks every 6 to 12 months for 5 years, then annually thereafter. Patients with stage 2B to 4 disease should have skin checks every 3 to 6 months for 2 years, then every 3 to 12 months for 3 years, and then annually thereafter. As we've discussed, the treatment of choice for most of these skin cancers is wide local excision. So if you have a biopsy-proven skin cancer, that's your indication. As we already discussed, for melanoma, your margin is going to be dependent on the depth of invasion of the tumor. So the important thing to note is that the circular area here around the lesion is going to be your margins, and the ellipse is really just so you can facilitate primary closure. That circular area around the lesion, you have to make sure you're getting full thickness tissue down to the level of fascia to make sure that you're getting all of the associated tissue to minimize your risk for local recurrence. And a nice rule of thumb for creating your ellipse to make sure that you have a tension-free primary closure is that the ellipse should be about 3 times as long as it is wide. So a 3-to-1 ratio length to width will help facilitate primary closure. That can be variable depending on the thickness and toughness of the skin where you're doing your excision. For subungual melanomas, amputation of the distal digit is generally performed to get an appropriate oncologic margin. For deep lesions, large lesions, or lesions in difficult areas to operate in, you can consider regional advancement flaps to help with closure as well. This slide is mainly just to show the pathologic evaluation of melanoma and how they slice the tumor to determine whether you have appropriate margins or not. And again, depending on the size of the defect or the location, there are various ways to consider closing it. Primarily, we'll close it primarily, but sometimes you might need a local or regional advancement flap or a skin graft or something that you can discuss with your plastic surgery team. Just to revisit the decision making for your sentinel lymph node biopsy, here's just a quick snapshot of what we already discussed. Whether depending on the tumor thickness and whether there's ulceration or other high-risk features, following NCCN guidelines, you can determine whether a patient needs a sentinel lymph node biopsy or not. And here's just an overview of the anatomy. If you are to perform a sentinel lymph node biopsy in the axilla or in the neck, the axilla, note that melanoma is different from breast cancer in that if you have clinically positive nodes and you're going to perform a lymphadenectomy, which we're going to get into, you need to get to the level 3 nodes, which are medial to the pec minor. And then keep in mind for the scalp, anything to the face or anterior or superior scalp usually is going to drain to your level 2A lymph nodes, sometimes 2B, and then posterior scalp is more likely going to go to the level 5A lymph nodes. Of course, at a lot of facilities, you'll be able to get some preoperative imaging so that you can localize the sentinel lymph node. You can just use that imaging to direct your sentinel lymph node biopsy. Again, if a patient has clinically palpable nodes, they might be indicated to have a lymphadenectomy. In the axilla, again, you want to get levels 1, 2, and 3 lymph nodes for melanoma. And for the groin, you want to do an iliofemoral lymphadenectomy. Just keep in mind that the lymph nodes typically follow the arterial supply to an area. So make sure you have a good understanding of the anatomy of where you're working and have a plan for closure of your defect, because you might have to make a sizable incision to make sure that you get enough lymphovascular tissue. For the groin specifically, there's a difference between a superficial inguinal lymphadenectomy, in which the fatty and lymphatic contents of the femoral triangle are cleared, which includes 5 to 7 centimeters above the inguinal ligament. Contrast that with a deep pelvic lymphadenectomy, where the inferior border is the inguinal ligament and the superior border is the bifurcation of the common iliac artery into the internal and external iliacs. An important point here is the MSLT2 trial in 2017 demonstrated that if you have a positive sentinel lymph node in melanoma, completion lymphadenectomy is not better than observation with serial ultrasound for metastatic melanoma. Therefore, current recommendation is if you have a positive node on sentinel lymph node biopsy, most patients can be observed closely with nodal ultrasounds every 4 months for the first 2 years, and then every 6 months for years 3 through 5, and then annually. In patients with bulky nodal disease, ones where you're planning to do a lymphadenectomy, they should get staging imaging, including a full body PET scan and an MRI of the brain to make sure that they don't qualify for systemic therapy prior to surgery, or to make sure surgery is not contraindicated. And a couple final things to think about with melanoma are in-transit lesions, which are metastases located within the regional lymphatic drainage, more than 2 centimeters from the primary lesion. Contrast that with satellite metastases, which are lesions that occur within 2 centimeters of the primary lesion. Management for these, as long as there's no extensive disease, you would proceed with a wide local excision of these lesions as well. Melanoma can also pop up in kind of unusual locations like the nail bed, the palms, soles, the genitalia or mucous membranes, even areas that are not exposed to the sun. And melanomas in these sites typically have a worse prognosis compared to cutaneous sites. As mentioned previously, subungual melanomas often require digital amputation. Melanomas around the genitals often require coordination with a plastic and reconstructive surgery team for optimal resection and reconstruction. And melanomas can pop up in the mucosa. These still have the same resection margins as for cutaneous melanomas, So obviously, if you have one in the oral cavity or in the anal cavity, anal canal, you want to consider, how your resection is going to affect the function in these areas. And that's our really quick overview of non-melanoma skin cancers and melanomas. I'll refer you to your SCORE curriculum and the NCCN guidelines and additional videos for further education, but this should get you started. Thanks.